Welcome to Spine Guy. I'm Dr. Brian Steele, a fellowship trained spine surgeon. The Spine Guy is a channel dedicated to making the complex spine simple for patients to understand. One of the most common questions I get in the clinic is, should I have spine surgery or do I have to have spine surgery? Approximately 90% of spine surgeries are elective, which means that you can take your time to think about and schedule the surgery and you don't have to rush into having surgery. There really is no threat to having permanent spinal cord or nerve injury if you wait on having surgery. Now, this is for a couple of reasons. The first is that in general, pain is not an indication that there's something bad or irreversible happening to your spine. Secondly, having surgery sooner rather than later does not necessarily lead to enough of a better outcome to warrant having surgery earlier. This video is going to give you some tools to help you decide whether or not you should have elective spine surgery. Now, before we talk about the elective spine surgery, let's talk about that 10% of the time when surgery does have to be done sooner rather than later to prevent further damage. Now, all these conditions are covered in my channel in different playlists, but let's go through a few of them here briefly. The first condition would be symptomatic spinal cord compression, which is also called myelopathy. This is covered in the central cervical stenosis playlist, but essentially if you have spinal cord that's symptomatic and it's causing things like problems buttoning shirts, handling coins, balance, weakness, numbness, then surgery sooner rather than later is indicated. Now, it's also important to understand that many patients have spinal cord compression, but they're not symptomatic, and those patients don't need surgery. Again, this is clarified in my other video. The second is a broken neck or a spinal fracture in the neck that's causing spinal cord or nerve injury. Next would be something in the low back called cauda equina syndrome. This is also covered in a whole cauda equina syndrome playlist. And this is when there's compression of the nerves in the low back that can go to the bowel bladder. They can cause loss of bowel or bladder function. They can cause global leg weakness as well as numbness. And lastly, when patients have compression of the nerves in the neck and cause arm pain, or the nerves in the back, which can cause leg pain, that's often accompanied by weakness. And that's because nerves do both sensation, but they also do strength, and they carry this signal down to each muscle. If the nerve is very compressed, sometimes patients can get significantly weak, and that can be concerning. Now, weakness is graded from 0 to 5. 0 is completely paralyzed, 5 is full strength, and depending on how much weakness you have is really how urgent the situation is. So weakness of 3 out of 5, 3 means anti-gravity. So in the terms of your ankle, if you can bring your ankle up barely against gravity and it just falls, that's a 3 out of 5. That tends to be more of an urgent situation. We usually recommend having surgery within 2 or 3 days of having that much weakness. Now, the majority of patients that have weakness have a touch of weakness. They're not 3 out of 5. They're usually 4 to 4 plus out of 5, meaning they can bring it up against gravity, and if somebody's pushing on the ankle, that ankle can still resist. Now, if there's a little bit of weakness and it's not full strength, there's definitely some more time to wait to see if conservative care can improve the weakness. Now, if weakness of 4 out of 5 lasts more than 6 months, then sometimes surgery doesn't have as good of an outcome. So I'll often reevaluate patients at the 6-month time point. If they're not having full strength, have a conversation about whether or not surgery would be indicated. And lastly, if there's progressive weakness, meaning if you're weak, but you feel like day by day or week by week, you're getting progressively and progressively weaker, then surgery would be indicated. Other than those few conditions, all other surgery in the low back or in the neck is really elective. So in terms of elective surgery, there are 3 things you should really think about. The first is, have you failed everything non-operative? If you watch all the videos on my channel, you'll see that the majority of the time patients don't need spine surgery. It can be treated by things like medications, injections, physical therapy, acupuncture, chiropractic care. Surgery should always be the last option. You and your doctor should feel like you've completely exhausted everything non-operative before even considering surgery. Now, number 2, a surgeon has to think that surgery might help you in order for surgery to be an option, obviously. I can't tell you how many times in the clinic where I tell a patient, I feel badly that you're in pain, but surgery just wouldn't help you. Now, surgeries have different percentages of success. You have to talk to your surgeon about the risks and benefits of each surgery, but surgeries can range anywhere from being 50% successful to 90% successful. It is really important to understand also that when we say that surgery is 90% successful, it doesn't mean that we take somebody from a 7 out of 10 to 0 pain. It means that we can take somebody from a 7 out of 10 to taking away the majority of the pain, which is more than half, and make quality of life better. It is highly likely that no matter what type of surgery you have, You're never going to be totally pain-free in your neck or your back. The purpose of surgery is to make you better than you are, not to make you perfect. Lastly, and most importantly, number 3 is you decide whether or not you should have surgery based on how much pain you have and how much it's affecting your quality of life. So let's talk about pain first. We usually grade pain from 0 to 10. It's something called a VAS score, or a visual analog score. 0 means no pain, 10 is the worst pain in your life. Everybody grades pain differently. Pain is something that's very personal. My 7 out of 10 is going to be different than your 7 out of 10. But in general, based on all the clinical research studies we have, we usually see patients looking to have surgery when their pain is something like to a 6 to a 7 out of 10. Now, again, that's very variable. That's just an average, but we're usually not seeing patients that have a pain of 1 or 2 out of 10 having surgery. Now, the real criteria for surgery is not just the pain level, but how much the pain is affecting quality of life. Impact on quality of life is the biggest reason to have surgery or consider surgery. Quality of life is something also very, very personal. I'll give you an example. Somebody may say, look, I have a pain of 2 out of 10 when I'm at rest and I'm doing most things, and I only have pain that's 10 out of 10 when I go golfing. So my natural response is maybe you just shouldn't golf. Now, a patient may say, I don't have to golf. There's lots of other things I like to do that bring meaning to my life, and I have a great quality of life not golfing. I just won't golf, and I can live with a pain of 2 out of 10. There's another type of patient who may say, I love golfing. Golfing is my life. In fact, I almost rather be dead than not being able to play golf. Golfing means everything to me. So in that situation, I would say the purpose of surgery is to improve quality of life. So if there's a surgery I can do to help take away your pain when you're playing golf so that you can play golf and have a good quality of life, then surgery would be indicated. Now, in spine research, we measure and we quantify quality of life using a lot of different surveys. Our clinic, in fact, uses quality of life measurements before and after surgery to see how good of a job we did and whether or not surgery actually helps our patients. The SF12 is a 12-question survey that's most commonly used and collected to really assess quality of life. There's 2 components of the SF12. One is called the PCS, which is the physical component score, and these are questions that measure your physical quality of life. Can you do the things you want to do? The other component is called the MCS, or mental component score, which measures mental quality of life. A lot of people don't understand that spine pain is very unique. Neck pain, arm pain, back pain, leg pain not only impacts physical quality of life, it's just as much impactful on mental quality of life. Changes in mental quality of life, such as depression and anxiety from pain, is a very real thing. And in fact, surgery has been shown to improve both mental and physical quality of life. Here's a good example of how we use quality of life to assess whether or not surgery can help somebody. This is a study that looks at cervical disc replacement versus fusion. And here you can see pre-surgery and post-surgery mental quality of life and physical quality of life components. And you can see how it improves with surgery. Now, calculating the actual SF12 score is very complicated, and I do not think you need to do that. But I do think it's important to look at a few questions within the SF12 to give you an idea of whether or not surgery might be an option for you to see how much your physical and mental quality of life are really being impacted. First, let's look at some of the questions within the physical component score. So, does your health limit you from moderate activities such as moving a table, pushing a vacuum cleaner, bowling, or playing golf? And does your health limit you from climbing several set of stairs? Next is, in the past 4 weeks, as a result of your physical health, did you accomplish less than you would like? Were you limited in the kind of work or activities that you could do? If you're answering towards the left-hand side of these questionnaires, meaning you're limited a lot in terms of your physical quality of life and that you accomplish less than you would like all the time and most of the time, then surgery might be a good option for you. Next, let's look at the MCS, or mental component score. So during the last 4 weeks, as a result of emotional problems such as feeling depressed or anxious, did you accomplish less than you would like? And did you do work or activities less carefully than usual? Next question is, during the last 4 weeks, did you feel calm and peaceful? Did you have a lot of energy? Did you feel downhearted and depressed? Again, if you're answering towards the left-hand side of the questionnaire, meaning you're accomplishing less than you would like all the time as a result of feeling depressed or anxious, or you felt downhearted and depressed all the time or most of the time, then your mental quality of life is clearly being affected, and again, surgery might be a good option. Other than the SF12, there's a couple of other body-specific quality of life questionnaires to understand. Again, I don't think you have to calculate these, but just understand the kind of things that you might be thinking about and how your life might be limited to see if surgery is an option. The first is called the ODI, which is a Sweatree Disability Index. This is 10 questions that looks at how much your pain limits you from lifting, walking, standing, sleeping, traveling. And you'll see here that this is even used in research studies where we're comparing whether or not surgery is better than not having surgery, improvement in the ODI scores. Next is the NDI, which is another 10-question survey. This is the Neck Disability Index. And so if you have neck and arm pain, how much does the neck pain and arm pain limit you from personal care? Does it cause headaches? Does it limit you from driving, sleeping, work, etc.? In conclusion, certain surgeries are non-elective. They should be done sooner rather than later. This includes spinal cord compression, cervical trauma, cauda equina syndrome, or severe or progressive weakness. Otherwise, the vast majority of spine surgeries are really elective, and these are the 3 things you should think about. Number 1, fail conservative care. Surgery should really be the last option. Number 2, a surgeon has to tell you that you're a candidate for surgery. And lastly, the pain that you have should be affecting your physical quality of life. You can't do the things you want to do. And also, and equally as important, mental quality of life. The pain's affecting you in a way that's causing depression, anxiety, mood changes, etc. For all these reasons, only you can decide if you want surgery because only you know how much is affecting your quality of life. As a surgeon, we are just there to help guide you along this decision-making process. Thanks for watching. Don't forget to click like and subscribe.